Celine Beltran.
Question 2, sir.
Mr. Speaker, sir, with your permission, may I address question 2 to 10 in today's order paper, please?
Please proceed.
Sir, during the Delta wave last year, our ICU wards come under immense pressure. This year, as we encounter the Omicron infection waves, and we have 3 so far, the pressure shifted from ICU to the regular hospital wards, and by extension, the emergency departments or the EDs. And this is because Omicron is a less dangerous variant, and our population has become more resilient due to vaccination and safe recovery from the infections. Hence, over the past year, I have reported to this House on several occasions that although we did not let the virus overwhelm our healthcare system, our hospitals, and especially the EDs, have been very busy. Why are the hospitals still experiencing heavy workload, given that life has gone back to pre-COVID-19 normal? The simple and fundamental reason is that the pandemic is not over. It may feel like it's over for most of us, but it certainly is not over for hospitals and our healthcare workers. We are learning to live with the virus as an endemic disease. And as I have explained to the House before, endemicity doesn't mean that the virus disappears from our lives. On the contrary, it means it is a permanent feature of our lives, circulating amongst us, and we have to take personal precautions, implement public health measures in order to manage it and live with it. What are these public health measures? Essentially, there are 3. First are the SMMs, safe management measures. It restricts social interactions and therefore reduce viral transmission. 2, transmissions still happen, and therefore we do vaccinations so that infections do not translate into many cases of severe illnesses and deaths. And when these 2 cannot prevent, the third lever, which is our healthcare system, will then have to manage. You have to catch the problem and then manage it by treating and caring for infected patients who become severely ill. So 3 things: SMMs, vaccinations, healthcare system. Now let's take stock of these 3 measures. For SMMs, we have removed almost all restrictions so that life goes back to pre-COVID-19 normal. And this is what all Singaporeans wish for, and the whole point of treating COVID-19 as an endemic disease. And therefore, the multi-ministry task force, we have been very reluctant to reimpose SMMs unless absolutely necessary. Second public measure, vaccinations. We have already covered the great majority, over 90% of our population. Vaccination exercise is ongoing, but this is largely to extend our coverage at the margins, namely now infants and very young children, and to keep vaccinations up to date for the others. So we are just maintaining our immunity and resilience, no longer able to achieve the kind of quantum improvement in resilience that we could achieve when we first started our national vaccination program. That means the burden of endemicity will fall disproportionately on the last public health measure, which is our healthcare system. And that is why our wards and EDs have been very busy over the past year. The media highlighted it only recently, but really our hospitals has been experiencing it for the whole year. I hope that as we enjoy our hard-fought freedom from COVID-19, we remember the toil and sacrifice of our healthcare workers, doctors, nurses, social care workers, etc. And they are sacrificing and toiling away in order to secure freedom and the state of endemicity for the rest of society. So COVID-19 may feel like it's over for many of us. It's not over for them. In the hospitals and EDs, therefore, service level may drop, waiting times become longer. Out of frustration, there will be public complaints, and we understand. But I sincerely hope that our hospitals and healthcare workers will continue to receive the appreciation, understanding, and support from all Singaporeans. Sir, now let me describe what exactly is the situation at the EDs today. First, I want to assure the House, for critically ill patients, they are attended to almost immediately at the EDs due to the way we triage patients and allocate resources. So priority always go to them. For non-life-threatening but emergency cases, median waiting times for consultation across all our EDs average about 20 minutes from January to September this year. It is not a very long wait, and it's important for this group of patients to be attended to quickly so that they are evaluated and then can be discharged promptly. For emergency cases that require hospital admission, that's where the bottleneck is. And the median waiting time for wards is about 7 hours, January to September. And this is a few hours longer than 2019. But what I quoted, 7 hours, is the median. There's a variation. So when we have an infection wave, like recently, waiting times can spike up sharply to the reported 50 hours for certain hospitals that are busier. Despite the heavy workload, our hospitals will not compromise the safety of patients. As mentioned earlier, life-threatening cases will be attended to immediately. If surgery is required, it will be carried out promptly and beds will be there for the patients. For non-life-threatening patients waiting for admission, medical teams will continue to monitor them and institute appropriate investigations and treatments. And for bedridden patients who are at higher risk of developing pressure injuries, hospitals will implement preventive nursing interventions. And this includes the use of thicker mattresses or air mattresses, turning of the patients periodically, changing of diapers and draw sheets for bedridden patients. This will be done. Sir, I will now address the most pertinent question, which is, what can we do about crowded EDs and alleviate the problem? Current situation, make no mistake, is not sustainable, and we need to resolve it. But it has not been easy to solve the problem, as we are still in the middle of a pandemic. Each time a wave subsided, and we started to deal with the problem, another wave will come. And attention and resources were diverted to fight fire again. With the XBB waves subsiding earlier than expected, we hope we now, this time round, have the time and space to deal with the problem properly and decisively. And to do so, we need to diagnose where exactly is the operational bottleneck. The issue actually is not the ED. It's really about matching the demand and supply of hospital beds. The crowdedness and long waiting times for patients at the EDs in some hospitals, especially during a wave, this is a manifestation of the problem, of a mismatch of demand and supply of hospital beds. So let's look at demand for hospital beds. If we look at average monthly ED attendances, which translate into demand for hospital beds, from 2019, before COVID-19 starts, to 2022, there is a reduction from 75,000 a month to 63,000 a month, patients per month. So translate to daily attendance is about 2,500 patients a day, 2019, to 2,100 patients a day, 2022. And this is a 16% decrease. Hence, it would appear that all our measures to educate the public not to go to EDs unless absolutely necessary, the GP First initiative, the setting up of urgent care centers in the heartlands as an alternative, they have all worked. Or there can be a simple reason, during a pandemic, people actually don't like to go to EDs. That is also a possible reason. However, while the overall number dropped, if you look at all the ED attendances, the proportion of patients with the highest acuity means they have the most serious conditions and need the most attention and probably need hospital beds, they had increased from 8% in 2019 to 11% in 2022. In absolute numbers, this is an increase of a few hundred patients per month. It's not huge, but it does add to the operational burden of hospitals. More importantly, I think, is this point, that this is, again, we're looking at averages. While average number has come down, during a pandemic, that number is a lot more volatile. So during an infection wave, many more patients, many more infected people and recovered patients, they go to the EDs. So for example, at the peak of this mid-year Omicron wave and the recent XBB wave, COVID-19 infected patients added another 600 ED visits every day. This is 30% more workload at the ED, which is very significant. I should mention a separate problem that we now encounter at KKH. The ED has been experiencing very high visits every day, at levels that they used to experience only during Chinese New Year when all other clinics are closed. So come Chinese New Year, I don't know what kind of numbers they are going to get. This is a separate problem due to what we call an immunity debt in children. It means that for the past 2 years, SMMs, including mask wearing, has shielded children from many forms of viral infection, and not just COVID-19. Now that life is back to normal, viral infections are making a strong comeback and demanding payback with interest. Now let's look at the supply side of the hospital beds. There are a few factors constraining the supply and slowing down the process of warding ED patients. First, due to our aging population, there is a secular trend of rising number of patients with long stays, and that reduces the turnover of hospital beds. To illustrate, the percentage of patients who stay longer than 21 days has doubled from 1.6% of all hospitalized patients, that's 2019, to 3.8% in 2022. Second, the pandemic caused construction disruptions, which delayed the opening of healthcare facilities, namely the Woodlands Health Campus and the Integrated Care Hub at Tan Tock Seng Hospital. If these facilities had opened as originally planned in 2022 without the COVID-related delays, they would have added at least a few hundred beds to our system and would have alleviated the problem. Similarly, construction delays due to the pandemic have also postponed the opening of several nursing homes and community care, daycare facilities, and that also constrained the ability of hospitals to discharge less acute patients and free up hospital beds. Third supply constraint, which is as part of our emergency planning, hospitals are required now to set aside or ring-fence beds for care of COVID-19 patients. Members of the House may recall, at the height of the pandemic, many PQs were filed to us, and at that time we were imposing SMMs to preserve healthcare capacity. And many PQs were filed asking MOH if we had planned for adequate healthcare capacity in such emergency scenario. Well, ring-fencing hospital beds for COVID-19 patients is part of that planning effort. However, we inject flexibility into the plan, raising or lowering the number of ring-fence beds according to the pandemic situation. So for example, again, at the peak of the recent XBB wave, we set aside 800 beds for COVID-19 patients, ring-fence. About 80% were occupied at the peak of the wave, which meant we still had 160 beds unoccupied for contingency purposes. Not a big number, but nevertheless constrains hospital operations and impede the clearing of patients waiting at the EDs. Whether due to demand or supply factors, we need to recognize this. That is, we run a very high throughput hospital system. And in such a system, even a very small mismatch of demand and supply, a couple of hundred beds, will cause waiting times to spike up very significantly. You think of it that way. It's not very different from an expressway with very heavy traffic flowing. All it needs is one branch fall on one lane or half a lane, and you have a massive traffic jam. We have a similar situation in a very high throughput hospital system. So how do we resolve the current problem? The hospital clusters working with MOH, they have issued a statement recently outlining all the measures they are taking, and they continue to be relevant, and we will continue to pursue them. Just to briefly recap, they include reduced ED demands through primary care, alternate pre-hospital care options, educating the public to use EDs only when absolutely necessary, diverting them to nearby primary care clinics, coordinating with SCDF to divert less serious cases away to less crowded EDs. We are also actively transferring patients in acute hospitals to step down or home care wherever possible. We are partnering private hospitals, such as Raffles Hospital, to accept patients sent by SCDF ambulances for emergency medical treatment, and also we offer subsidized rates, even though it's treated at Raffles Hospital. New nursing homes are coming on stream, and they are very helpful during the XBB wave. From the end of next year, Woodlands Health Campus and Tan Tock Seng Hospital Integrated Care Hub should start to open progressively. And over the next 5 years, we target to add about 1,900 more public hospital beds, including the above two projects and also the expanded SGH Medical Campus. But today, let me focus on two important structural adjustments that we will make, which will hopefully help alleviate the crowdedness at the EDs in the short term. Number one, we will activate more TCFs, what we call transitional care facilities. 3 TCFs are already in operation with a total of 400 beds. These are operated by private providers at wards at Sengkang Community Hospital, Changi Expo Hall 10, and Crawford Hospital along Farrer Road. And that one just opened last week, a few days ago. The TCFs serve a special purpose. They admit medically stable patients from public hospitals while they wait for their transfer to intermediate or long-term care facilities or for their discharge plans to be finalized. It is therefore a very important step-down care facility to free up acute beds in hospitals. But TCFs are not just about providing bed space that's operated by private hospitals. There has to be a very firm handshake between the TCF operator and a public hospital. Because with that firm handshake, the privately operated TCF will gain confidence in admitting patients transferred by a public hospital, because they will feel assured that should they need any clinical help, in the unforeseen circumstances that some complications, the public hospital will still step in. Without this understanding, TCFs will naturally be very conservative in admitting patients, and there will be very little movement in stable patients. The Sengkang Community Hospital TCF is run by Thomson Medical Center. That's a very good example. They have a very strong partnership now with Sengkang General Hospital. We will replicate this to pair up Changi General Hospital with Expo Hall 10, run by Raffles Medical Group. Tan Tock Seng Hospital with Crawford Hospital. We are actively working on new TCFs in the north and in the west to partner Khoo Teck Puat Hospital and Ng Teng Fong General Hospital, respectively. Second structural shift, our approach to live with COVID-19 needs to be extended to hospital operations as well. And it is time for us to adopt a more flexible and balanced approach to hospital bed assignments. We should move away from ring-fencing beds just for COVID-19 patients. We had done so in the earlier stages of the pandemic, when hospitalized COVID-19 patients face a very high chance of developing severe illnesses, and numbers can spike very high during an infection wave. Hence, reserving beds, actually we reserve wards, is an appropriate thing to do. However, we are now at a stage where most residents have been vaccinated and boosted, or recovered safely from COVID-19, and have good levels of hybrid immunity against severe illnesses. We should therefore allow hospitals to triage or assess their patients based on clinical severity and priority for treatment, and not manage COVID-19 patients to a different standard. This flexibility is important to our hospital to help them optimize the use of beds. In a crunch situation, just like the expressway with very high throughput, it makes all the difference. With this change, hospitals will no longer set aside whole wards to cohort COVID-19 positive patients as a standard pandemic practice. They will continue their current practice of using isolation beds for patients with infectious diseases, including COVID-19, if there is a risk of infection spread. This is not a sudden change, but a transition process that has started and ongoing. Hospitals will continue to exercise various precautionary measures on infection control to protect the vulnerable and prevent spreading of infectious diseases in hospitals. They have done so for many years, for influenza, for all kinds of infectious diseases. They will apply the same measures now for COVID-19, but without setting aside entire wards, which will stall their operations. Beyond these two structural measures, every one of us can do our part. While ED attendances have fallen compared to 2019, non-urgent cases still make up 40% of all ED attendances. We can use EDs more judiciously, use alternatives such as a GP clinic or call our family doctors. We should exercise social responsibility, such as staying at home and self-testing when not feeling well. Most importantly, we need to continue to keep our vaccinations up to date and prevent ourselves from falling severely ill if we are infected by COVID-19. Today, a senior without minimum vaccination protection is still about 3 times more likely to end up in hospital and needing to be warded than one with minimum vaccination protection. So by taking another jab to keep vaccination up to date, you may well be freeing up an additional hospital bed. If we can do our part, we will help healthcare workers earn back their normalcy of life as they have sacrificed and worked hard to earn our freedom and normalcy of life. Thank you.
Dr. Lim Wee Kiak.
Sir, I welcome the Minister's announcement of a new direction. Instead of ring-fencing bed, I think we will treat it as almost like an endemic situation. I would like to ask 3 SQ. One is, what is the estimated backlog?
You can keep it to 2, please. Thank you.
Okay. What's the estimated backlog for the elective surgeries that we are currently facing now? And what is MOH doing now? And when will we clear this backlog?
Thank you. The backlog is not huge because ever since we moved to start opening up, hospitals have all realized that to postpone electives and postpone non-urgent surgery, actually it all comes back after a while and with interest usually. So for the past 2 or 3 waves, I can't remember, we have been very reluctant to postpone these electives. In the recent wave, we postponed some, but only 5%, 10%. So it's not a huge backlog, and certainly we will want to clear it as soon as possible.
Mr. Lim Bao Chuan.
Thank you, Speaker. May I ask the Minister, what can we do to encourage more clinics to open up 24-hour services? Earlier this year, my 90-year-old mother was ill, and I just found it so difficult to find a 24-hour clinic. So if the MOH can encourage more clinics to open for longer hours, that would certainly help, because otherwise my option is to send her to an emergency department. Second question, sir, is the TCS. Would there be a difference in costs, because this would be run by private clinic? So if I'm a patient going to TCS, I would be concerned about the costs. And finally, what is the percentage of spaces available when you free up the number of beds for COVID-19 purposes?
Thank you. Short answer, we'll try to encourage, but 24-hour is not easy. They will need a few doctors to cover each other. But many clinics today do open late at night, and hopefully with something like Healthier SG, we are changing the mindset of GPs and also changing health-seeking behavior. Hopefully, we will get more help from GPs in attending to some of these urgent cases. For your mother, if it's middle of the night, I think going to ED is probably justified. 2, TCF costs no different from public hospital. We are running it and subsidizing it in the same way. And finally, the percentage of or number of beds that would be freed up. I gave a ballpark just now. At the peak of Omicron XBB wave, we were still setting aside 160 beds at the peak that sterilized it, ring-fenced it, even though we had patients waiting downstairs because we were afraid of a spike of COVID-19 patients. But when off-peak, the number is actually larger. So I would say at least 200-300 beds, and I think they will make a big difference to the operation of hospitals.
Mr. Hon Wing.
Thank you, Mr. Speaker. I thank the Minister for his reply. I have two SQs. First, I'm heartened to hear that our TCFs will be paired with our hospitals. Notwithstanding, will there be enough healthcare workers to run these TCFs given the overall tightened manpower situation in our hospitals? Second, how is MOH supporting our healthcare workers to do their work more efficiently and to prevent burnout during this period of high patient load? Thank you.
We know healthcare workers is never enough. There's a manpower crunch and intense competition between different countries trying to hire healthcare workers. Fortunately, this is something we can solve in the short term over a few months, recruiting, training them, and putting them in place. So this is something actively we are doing. Now that COVID situation has stabilized, borders are opening up, we have started our overseas recruitment process, as well as continue to work with our local institutions to bring in more healthcare workers. Second question, how to prevent burnout? If we solve all these jam problems, manage pandemic, and move to an endemicity form of operations, I think it will go to a great extent to reduce the workload.
Mr. Jerrigan.
I thank the Minister for his reply. I deeply appreciate all our healthcare workers and staff, from doctors to nurses to hospital receptionists, for their tireless efforts in caring for patients. Both they and the patients suffer tremendous stress when the queues of patients build up. So I have two clarifications for the Minister. First, I understand that some patients are not discharged because the downstream care facilities are not available to receive and accommodate them. The Minister said just now that there were some delays in the opening of nursing homes and daycare facilities, and transitional care facilities are being used to reduce the burden on acute care hospitals. Can the Ministry also look into providing more home support for patients to help their families care for the patients who are suitable for discharge from acute care hospitals? And secondly, queue clearance depends in part on the ability to triage and diagnose arriving patients, and this in turn is limited by the number of qualified healthcare professionals. Is the Ministry looking at giving greater responsibilities to nurses so that they can take on more of the responsibilities that are currently being done by doctors? Thank you.
Thank you. We are certainly looking at home discharge as well. In fact, that's a major initiative. So in a complex system like that, it's all of the above. Whether it's nursing home, step-down care, community hospital, home discharge, we look at all of them. Just a point on home discharge, actually it is quite manpower intensive, because once you bring a patient home, a nurse do have to visit them, call them, but you free up the bed spaces. So it does add to the workload of nurses. So we are managing different resources as optimally as we can. But this is a major area that at some point we should discuss further with Healthier SG, aging in place. Home nursing is actually a very important prong. Second, triage. I think nurses are already doing some of this triage, and certainly with our move to Healthier SG, preventive care, bringing healthcare into the community away from the hospitals, there's a lot more our nurses, allied health professionals, pharmacists can do. It's a direction we are moving towards.
Sung Ling Ling.
Thank you, Mr. Speaker. I also want to express my deep appreciation to our healthcare workers, especially the doctors, nurses, and staff working in the EDs, some of whom are my personal friends, and I've seen how they have persevered through these few years of COVID, and I'm journeying with them. I have two SQ. Pertaining to the GP First initiative that was first piloted in CGH back in 2014, can I know how many of our current slate of about 1,800 GP clinics are on it? My second SQ is that I spoke to some of the GPs in my Jalan Kayu constituency about the situations in the EDs and what's the role that they can play, especially under Healthier SG, to be part of the solution for the ecosystem. And they have asked whether there can be more practical resources, such as a peer-to-peer call line, for them to reach out to their A&E doctors' counterparts in the public hospitals in the region, so that they can triage and also assure the patients that actually the conditions may not warrant an ED admission. Thank you.
Thank you. First question, I do not have the number. Maybe submit another question, file another question. GP can certainly take load off the EDs. Number one, open 24 hours. If not, open at night, make yourself available through medicine. You can assuage the concerns of many patients and avoid their ED visits. As to whether they want a call line to EDs, I suppose the more they call you, it does add to the workload of EDs as well. But notwithstanding that, I think we can approach AIC, and AIC will help link up with the nearest EDs.
Joan Pereira.
Thanks, Speaker. Minister, I have one SQ. There may be elderly facing non-life-threatening cases who may not have been able to share their condition while waiting for a doctor to see them at the A&E. They may have felt nauseous, cold, scared, hungry. How then does MOH identify, or how then do the nurses identify such cases and help comfort them during that waiting period? Thank you.
When the queue is long and you start to have crowded EDs, of course, the nurses do that. I think they have the skills to do that, including the language ability, because in a team there will be multiple language skills, and they were able to comfort the elderly. I think the problem that the member raised is probably a result of very crowded EDs. Nurses are under tremendous pressure, so the kind of attention is probably not given compared to normal times. So I think we still go back to the same problem we raised earlier, that if we can resolve the crowdedness at the EDs, I think the problem that the member raised will be addressed.
Mr. Liang Eng-Hua.
Because the minister mentioned about the non-urgent cases attended by EDs, and I understand some because the clinics couldn't cope and refer the patients to EDs, including some polyclinics, I understand. So can I ask the minister, he mentioned about TCF, whether that can be also another place where clinics can refer patients to the TCF instead of going to the EDs? Yeah.
TCS is not quite the place to refer ED cases over. It's more a step-down care. Yeah, more a step-down care facility. But what we are doing is setting up more UCCs, urgent care centers. We have one in Admiralty, and that has been very useful. But ultimately, go back to how we diagnose the problem. Reducing non-emergency cases to EDs certainly will help. But that is not the main bottleneck today. The main bottleneck remains a mismatch in demand and supply of hospital beds, which lead to long waiting times at the EDs, waiting for wards and crowding the EDs. So that remains the most urgent problem to be resolved.
Mr. Pritam Singh.
Thank you, Speaker. Minister, just a question on the situation at Kandang Karbala Hospital, KKH. Minister spoke about the heavy demand on beds there. Does the Minister have some indication as to when that demand is likely to taper? Or is it a case of they're having to stand up more beds in Kandang Karbala Hospital over time?
The bed situation for for peds is actually quite okay. Yeah, we don't have it's a different problem from the EDs of the other hospitals where there's a mismatch in demand and supply of beds. For children beds, it's actually okay. This is more a case of ED visits where they can be attended to, treated, and discharged and go home. When will this subside? I mentioned it's an immunity debt, which means it can over time be repaid. As to how long, I have to consult the experts in MOH, and they may have some idea.